Hi, I am Dr. Frank Opelka, a semi retired surgeon and health policy expert. As a surgeon, when out for a sunset stroll around the neighborhood, we get to chatting with friends along the way. Every now and again, one of the neighbors asks about their own health or a loved one, where to go to find good care. More of my friends are leaving middle age behind and seem to need care for this ache or that. For anyone, it is hard to know where to find the care they seek. The details about care are hidden behind secret walls. For some, it is women's health or aging men with failing parts. For others, it is an unexpected and complex problem. As patients, people are aware of the complex systems of care, wondering how to find the right doctor. Who is the right fit, and can they rely on word of mouth or their PCP's preference for a specialty referral? Is it the right team? Every hope is their PCP may know or have only heard great results from her referral to a specialist. What is really behind their questions is something I created as a framework, and I like to call this framework the three proofs: proof of service, proof of safety, and proof of benefit. Before we take these three proofs apart to understand them better, first, we need more clarity about what is behind this sort of care and referral. What we are talking about is not just one office encounter, not a one and done moment. This is a handoff to a specialist to help assist or co manage a situation. If we are talking about something that is more than an encounter, what is it? Well, when we pull a set of related encounters together for a patient's problem, we are grouping them using grouper logic. The grouper logic calls these episodes of care. An episode is a group of clinical services pulled together over a set period of time for a specific reason. Episodes can be a condition episode or they may be triggered by a procedural episode. Condition episodes include such things as diabetes, congestive heart failure, or osteoarthritis. Even pregnancy is a condition episode, it is not a disease. Episodes can also be procedures like a cardiac cath or a joint replacement, cataract operations, a transplant or endoscopies, and more. Some are 30 days long, some are 12 months. Prevention therapies or screening care are special classes of episodes. Physicians band together in their various communities to become episode care teams that work to deliver on three proofs for each episode. You know them as cancer centers, trauma care, or a digestive disease center as examples. And some patients may have more than one simultaneous episode with many conditions and procedures overlapping. Let's return to that neighbor down the street. Three or four ongoing chronic episodes managed by his PCP. However, the care has gotten complicated and the time has come for a specialty referral or some proceduralist with a potential intervention. Before long, the referral leads to tests, diagnostics consisting of labs and images, etc. A diagnosis, once established, fixes a label to the episode, and suddenly there is a treatment plan, medications, or even a surgical procedure. The neighbor's questions started coming long before things get too carried away. Let's go back to the three proofs. These are in the back of the patient's mind, out of focus because their illness has preoccupied them. Proof of services. All the services are aggregated over the time period. What services are needed to establish a diagnosis and secure a plan? How many are actually necessary and how many tests are overkill? After all, these diagnostics are not cheap and copays are adding up, not to mention access to tests, delays, time, and so forth. All these services represent the work and the cost of care. It would be great to know in rough terms what this will cost. In today's world, patients deserve to have a general idea of the proof of services. It should be readily available. Proof of safety comes from all the potential adverse events or harms related to medical care: drug interactions, allergies, complications, missteps, and more. It seems the more complicated the care, the more the risk of a failure interrupting the best intentions. Add to the mix patient factors like social determinants, poverty, education, access to care. All of this adds up. The impact is what insurers and payers seem most interested to avoid adverse events or costly complications. When a good procedure goes badly, the patient suffers and the costs seem to rise. These are the nightmare stories about healthcare on the news, in movies, and the chatter around the neighborhood. Thankfully, adverse events or harms are rare. Much more good comes out of the care delivered. If we can get past the proof of services and the proof of safety, avoiding harms, we finally get to the proof of benefit. The reason for seeking care: a patient has a need, a goal, and to some degree that goal was met. It is occasionally measured on a 5-point Likert scale, with the highest goals exceeding a score of +2. Unfortunately, rarely are scores ever measured. Mostly, proof of benefit is unknown and relies on word of mouth. The accuracy of this rumor mill is just not good enough for making the most important decisions about healthy outcomes. What do I tell my neighbor? My patient version of the three proofs is to talk to their PCP about team based care. Look for who has the best team, high volume, experience with complex patients, who has knowledge about price transparency, and see if it is about the entire cost of the episode of care, who has good rankings for safety published. What does their insurer know? And are they sharing the news? Finally, look for reliable sources for proof of benefit. Talk to patients who are willing to share and offer their guidance. Healthcare is wonderful and it is complex. It is best delivered by a working team coordinated in an advanced system. That's where you find the three proofs.